All right. Hi, everybody. Dr. Jason Ho, thank you for the introduction. Thank you for spending some time with us. As they mentioned, Kelly mentioned, I am a shoulder and elbow surgeon. And I kind of want to go over this webinar as how I would approach patients and how I want patients to kind of think about their shoulder when I see them in the office. So first things first, our goals for today are really first to define shoulder pain. Shoulder pain can also come from other places, not from the shoulder. That's one thing I always like to think about. The other thing is talk about any diagnostic workups or things that may um, be worked up while during your shoulder visit. And then ultimately discuss potential treatment options, once we kind of identify what the different issues are. So that being said, shoulder pain can come from many places. It can come from the neck. It can come from nerves. It can come from things outside the shoulder. Sometimes the elbow itself can also cause some shoulder issues. And so the fact that you feel pain in that shoulder region may mean things it might be coming from other places as well. So what is the shoulder joint? From a bony standpoint, at its most basic, it's made up of three main bones. One is your humerus bone, which is your upper arm bone. You can see on that slide there. The next thing is the shoulder blade. That's the other object that can potentially be a source of pain. And also the collarbone. Now, those are just the bony structures. The shoulder is more than just bones. It's soft tissue, it's nerves, sometimes blood vessels, and problems with blood vessels can cause shoulder pain. So it's a pretty complex structure. Now, when I first like to ask patients, think about your shoulder. These are some x-rays of two different shoulder problems. Is it chronic? Is it acute? Has it been going on a long time? Has it going on for just, a few days? Did you have a big trauma or an injury? As you can see, this patient over here on the left side of the screen had a big fracture from a fall, whereas the patient on the other side of the screen has some arthritis, probably been going on for a long time. The interesting thing is that you can have a chronic problem that also presents acutely, meaning, you flared it up and it's something you dealt with before, but it really didn't really present itself till more recently. So that's something that can also happen too. Let's see here. The other question I like to ask patients to think about is, do you have any issues with um, prior surgery? Have you had a prior replacement, as you see on the left side of the screen? Have you had a fracture that need to be fixed with plates and screws before? Or sometimes one of the most common surgeries in shoulders, have you had prior rotator cuff surgery? Because these are things that we think about and become part of our discussion point and help us lead us down a track of where the problems or the causes of your shoulder may be coming from as well. So, whoops. So next slide. So, what treatments are there we have? Well, there's a variety of different treatments. We can do physical therapy. It's kind of covered by this one slide. In addition to physical therapy, we can do injections. Things like ice and heat, over-the-counter anti-inflammatories. Those are all things we can do. But the one thing we try not to do with any sort of these type of pains, unless it's an acute setting with emergency, is opioids, because we found out through many years of initially prescribing opioids for a lot of this that it doesn't really help the problem or the pain, and actually can cause more problems. So really, when I say non-operative treatment, it's a thing of changing your activities. Do you not lift as much weight? Do you change your exercises now? Do you not do certain things? Have you tried Tylenol, Advil, over-the-counter stuff, or even prescription stuff? And those are all things that we think about. In addition, we think about relevant medical issues. Patients like diabetics are at higher risk for conditions such as frozen shoulder. Patients who have a history of rheumatoid arthritis may be on some medication that cause some other issues, or they may have different patterns of how their shoulder pain or other pain around their body presents. And then if we ever talk about surgical interventions, things from your heart and lung, those all become very central and important. So after discussing some basic issues around your shoulder, we have to work you up. When I tell folks, I can probably make a diagnosis of your problem the vast majority of the time with just a good set of x-rays. Ones that give me 2 views of the shoulder, I can get an idea of what's going on. I can rule out big bad problems like fractures, dislocations. I can identify arthritis, and that in combination with my physical exam, I can figure out a lot of the soft tissue problems too, like rotator cuff injuries, things of that nature. Besides x-rays, oftentimes people always ask, well, when do I get an MRI? Do I need an MRI? Well, the MRI is most useful when the diagnosis is not clear based on an x-ray and the examination, and also, more importantly, for surgical evaluation, surgical discussion, and surgical planning. So here on the left side of the screen, there is a rotator cuff tear. And what you can see here on the rotator cuff tear is that, I'm going to turn, here we go, here's my drawing here, is right here, there's a white area. Now that white area is a tear. This more black area is the tendon, and that should connect all the way over here. And so this is an example of how an MRI will help me diagnose a rotator cuff tear. This specific patient, I had an idea that he had a rotator cuff tear, but I got the MRI because he was a young active patient, and we were discussing whether to treat this surgically or to continue some non-operative management. He ended up having a big enough tear that we did surgery. Now, findings can be more subtle, as you can see on the right side. This is another MRI scan of the shoulder. This is the ball. This is the ball here, and this is the socket on this side, as you can see. But something more subtle, like this little cleft of white fluid in between a triangle there, shows me this patient has a labral tear. He's a younger patient. He had a dislocation event. This MRI helped me diagnose what I suspect he already had, and also have surgical discussion with the patient. So the MRI is quite useful if the x-rays and exam are not perfectly clear, and to discuss surgical planning. Sometimes I do order a CT scan for patients. It is usually a bony CT scan. And when we do this, it's usually to define your arthritis, your bony anatomy. And for some fracture cases, it's more for defining whether or not I might do surgery. And then for my replacements, I do 3D modeling, as you can see in this middle picture. And this 3D modeling will help me figure out where to put my implant, what size implant to do, and things of that. Other diagnostic tests I do also consider. One is an ultrasound. This is something I do concern patients who are unable to get an MRI. An EMG is a nerve test. It's a very uncomfortable nerve test for anyone out there who has had one, so I do apologize when I order this, but it's very useful. It's the only way to really get a good idea of any nerve problems are going on. And I use injections not only for treatment, but also for diagnosis when I'm not sure where pain is coming from, because pain can come from 3 different areas in the shoulder. I'll kind of go over that, and the injections can help me isolate that. And aspirations, which is taking fluid off the shoulder, I do that at times usually when working up an infection or like a painful joint replacement. And sometimes when everything doesn't really make sense, I do get some imaging of other body parts. I've done MRIs of the cervical spine to kind of rule out any cervical spine issues. Sometimes the elbow of an X-ray of the elbow or other imaging is also very useful to that. So when I mentioned earlier, there are 3 parts of the shoulder that are really important to think about. One is the AC joint here. That's an area I can also inject, and sometimes that's a source of pain. The other is the area above the joint, which is in this bursal area that's kind of identifying this picture. This is on top of the rotator cuff. A lot of times rotator cuff pain is in this region. And then there's a region that's inside the joint here between the ball and the socket. And oftentimes an injection, if the rotator cuff is not torn, will be contained in each of these 3 spaces that can help me identify where the origin of your pain is coming from. So the first thing I like to talk about is rotator cuff disease. It's extremely common. Millions of Americans are affected by this every year. It can vary from something as minor as tendonitis, which is inflammation of the rotator cuff, the biceps area, inflammation of the bursa, or it can actually be a tear. But a tear can, I like to define tears as the people think about they're a pair of jeans. Tears can be some fraying on your jeans, or it can be a hole so big they can actually put your finger through your jeans. So those are all classified as tears. And tears are actually more common the older we get. If I got an MRI on everybody of on 100 people over the age of 55, let's say, with no shoulder pain at all, 50% of those people have a tear of some sort, and 25% of those people would have a hole in their rotator cuff that goes all the way through a full thickness tear and not even know it. And so the tear is something that does happen with aging, but it can also be because of pain. So just seeing a tear but having no shoulder pain is one thing, but seeing a tear with shoulder pain is another thing. And then at times, some patients may have rotator cuff tears not knowing, over time develop arthritis within. That's what you call rotator cuff tear arthropathy. And all these different entities of rotator cuff disease can be treated non-operatively and then are successfully treated. I have a lot of patients who I do physical therapy, prescribe physical therapy, do injections, and they're managed and they're happy. And I see them, once or twice a year. But for some patients, those non-operative treatment options we talked earlier just don't work at all. So that's when problems arise. And so what is the rotator cuff? Well, it's a group of 4 muscles in your shoulder. There's the subscapularis here in the front. Okay, you have the supraspinatus up top, and then you have 2 in the back, the teres minor and infraspinatus. And it does 2 major things. One, it keeps your ball in the middle of the socket and also allows your arm to rotate in space. So when you're rotating your arm away from you, those are things that the rotator cuff does for you. Oftentimes when people have a full thickness tear and surgery is indicated, we do repair the rotator cuff. It is a good surgery. However, it is probably the worst post-operative recovery out of everything I do. For the people who are manual laborers or don't have light-duty work, I tell them it's a 6-month at least recovery before I return to full-duty work. 3 months before we even start strengthening in general. And for me, the vast majority of these are done arthroscopically. You can see here on the top left, this is a rotator cuff there. This is the tendon. This tendon should be right here. But in this patient, they had a full thickness tear. And we usually tack it down by using some sort of heavy suture that we anchor the bone. And you can see the suture is now tied down the tendon. So that hole between the tendon and the bone no longer is there. Now, sometimes these rotator cuff tears become not repairable. So I tell people to think about a tendon like a rubber band. If you cut it, it'll spring back and you can pull it back and forth. But if that tendon has been cut for a long time and it's kind of retracted and it hasn't been stuck there, it's a chance that when I start pulling on it in surgery, it's more like a piece of leather. It's not very elastic. And so what I showed, this is the tendon in this patient down here in that arthroscopic image, and I somehow need to pull this all the way over here. And in this patient, that's not really a possibility. And in this group of patients, there are a variety of treatments. That's a very hot topic debate. This is always at our national meetings. There are seminars on this. There are symposiums. So this is a very topic of debate. And there's a variety of treatment options. I apologize. This was an animated slide, and because of the online nature, but I can do things such as debriding the rotator cuff, where I just clean off a little bit of it. I can repair part of the rotator cuff. I can do a muscle transfer, where I take a muscle from your back and hook it up to where the rotator cuff used to be. There's a new product coming on where you can put a biodegradable balloon into your shoulder to kind of create the buffer between the rotator cuff and your shoulder blade bone. And then sometimes in really bad cases, I even do shoulder replacements for this, which you see here. This is a reverse shoulder replacement, I'll go into a little more later. Patients who have CTA or cuff tear arthropathy, which is the arthritis-associated rotator cuff tears, most likely the only reliable surgical treatment is reverse shoulder replacement. And it's reverse, as you can see, the ball here is on the socket side and your old ball becomes the socket, okay? And so that is why it's called a reverse shoulder replacement. Essentially, it replaces a rotator cuff. It uses your deltoid muscle, which is over here on the side, as the muscle and the power to lift your shoulder. It no longer requires a rotator cuff. And it is a really good operation. It won't give you a perfectly normal shoulder, but it'll get you pretty close. On average, my patients a year out after surgery from a reverse replacement tell me their pain is somewhere between a 0 and a 2. They're usually starting anywhere between a 5 and a 10, 10 being the worst. And their function, when I ask them 100% is a normal shoulder, they'll tell me it's about 80 to 90% of the year after surgery. So it's pretty good. It gets you pretty close. It gets you good function, really good for pain relief, and pretty good for function. The things that it does not do as well because of design, overhead, instead of all the way up overhead, it may just be a little less. And now the biggest thing is behind the back doesn't do as well. And that's the nature of design because of the implant and the ball and the socket are reversed. The other thing I like to talk about in the shoulder is arthritis. Arthritis can be glenohumeral or shoulder joint related, which you can see in this patient. There's no more joint space remaining. The ball and the socket are kind of touching. He's got bone spurs, and it can be in the AC joint up here. AC joint arthritis, we often treat with injections. We can also treat with surgery. We can do an arthroscopic procedure where we clean up the bone spurs. Most of my patients, I just treat with injections every few months, and they're happy. It flares up, I give them an injection, but it's never so frequent that they consider surgery. A handful of patients I do an arthroscopic procedure on. But the big one is the glenohumeral arthritis, or shoulder joint arthritis. These patients, non-surgical treatment really is injections for pain relief, some physical therapy and stretching to keep the range of motion. And oftentimes therapy might flare it up because of the arthritis. I tell patients, imagine the rubber on your tires are worn out and you're riding on your rims. Sometimes if you use it more, it might get a little worse. It doesn't feel as smooth. You might have some grinding, popping, clicking, catching. And eventually it gets to the point where your arm is no longer a benefit to you, it's real liability what you do. And that's really the time to consider surgical treatment. And surgical treatment for the shoulder is kind of replacement or non-replacement. You can see this patient on the left side of the screen here. They have end-stage arthritis, the ball in the socket. They are worn down all the way, huge bone spurs. This patient would not be a great debridement candidate, which is when I go in arthroscopically, clean up the bone spurs and anything that might be causing problems. And that's because he's got such advanced arthritis. I typically reserve these the arthroscopic procedures, the non-replacement procedure for patients who are manual laborers. They're very young. The replacements are a good option, but they do have a shelf life. On average, 20 years out, 80 to 90% are inpatient. So if you're a 40-year-old, 30-year-old person with end-stage arthritis, you're almost, I won't say guaranteed, it's a very high likelihood you'll have a revision surgery at some point in your life. But for some patients, the arthritis is so severe that replacement is the option. And then there's behind this image, this image right here shows a normal shoulder replacement where the ball is a ball and the socket's a socket, and then the reverse shoulder replacement. And depending on your rotator cuff status, how much bone you have left on the socket side, a variety of things, those are the two major options. And some patients may also be considered for a partial replacement, where I only replace the ball side here with the shoulder replacement and leave the socket. And the biggest benefit of that is usually I put a piece of plastic here so I can replace the socket. But if you only replace part of it, you still have some pain from the socket side. So your pain relief isn't as good, but you don't have any restrictions ultimately because of the replacement. I like to tell folks you're thinking about probably a 20-pound weight limitation after replacement for life. You can do that every once in a while if you need to move some mulch or some fertilizer, not a big issue. But if you're lifting that daily on an everyday basis, you're going to wear the pieces and the parts out pretty fast. And then a revision procedure may be more likely than not. Some other things I like to talk about outside of that are fractures or trauma. I see that a lot too. That usually runs in the acute pain category, the acute shoulder pain, the proximal humerus, which is the shoulder bone here, the clavicle, which is this, can get fractured, or collarbone. And sometimes you fall, can separate your AC joint, which is there. The vast majority of these cases can be treated without surgery. Here's an example of a patient I saw, had a proximal humerus fracture. I treated her without surgery and it healed up. This is her 3-month x-ray. Both shoulders are up. She was back to work, no problem. She was very happy. She avoided surgery with this. And so a lot of times these can be treated without surgery, but when they are, displaced or in a position where they may not heal and with good function, surgery is recommended or discussed at least. And that can be done usually plates and screws, or in some cases of the proximal humerus, that a replacement might be the best option for you, depending on how bad the fracture is. Another thing I want to do mention about proximal humerus fractures, it is considered what we call a fragility fracture, meaning it happens in patients who don't have great bone mineral density, or maybe osteopenic or osteoporosis, meaning their bone isn't that strong. And so I do oftentimes get these patients hooked up with either a metabolic bone doctor or send a message to their primary doctor to talk about trying to increase bone strength. Calcium, vitamin D. We live in Northeast Ohio. The sun is out very infrequently here, and almost the entire population has vitamin D deficiency. So those are some simple things that can keep your bone health as well and decrease the risk of some of these fractures. Another common injury we see, shoulder dislocations, frozen shoulder. Shoulder dislocations are from a trauma, but it becomes different depending on your age. In the older age population, the rotator cuff is something we think about because that is oftentimes what is damaged with the dislocation. the labrum in younger patients. And the surgical decision making is very complex. A lot of these patients can be treated non-operatively with physical therapy to strengthen the rotator cuff for what's left. But if there is a tear or an acute tear, or if there's a bony injury associated with this, surgical decision making and surgery may be indicated, but it's very independent. It's an individualized thing I like to discuss with patients depending on their age, their activity level, what their job is, things they need to do. Another thing that's seen in patients I see is frozen shoulder. Frozen shoulder is interesting. It has another name called adhesive capsulitis. And we don't know where it comes from. We know middle-aged females are at higher risk. We know Asians are at higher risk, and we know patients with endocrine abnormalities such as diabetes or thyroid disease at higher risk. We don't know why. We don't know where it comes from, but it typically does have a very predictable pattern of how it goes. It usually starts out with a pretty minor injury, minor trauma. Something you bump your arm into a car door, or hey, I painted a wall over the weekend. Starts out from a painful phase, and after the painful phase, it becomes painful and stiff, and painful and stiffness. Eventually, the pain kind of goes away and just stiff, and the last phase is the thawing phase. If we ignored all frozen shoulders, they would take care of themselves, but it usually takes up to 2 years to do it, which is pretty unreasonable. So we try to speed up that process by doing interventions such as injections, focused therapy on stretching. And this takes care of probably 90 to 95% of the cases. Very rarely do I operate on frozen shoulders and have to do a surgical release. And that's usually an arthroscopic procedure or manipulation or anesthesia when you're asleep, and we move your arm to get the range of motion back. And usually the patients who fail non-operative management are patients who have prior surgery and have a frozen shoulder, and ones with a history of diabetes. We don't know why, but those are the patients who are at higher risk of failing non-operative management. And the less common thing I see, I do want to mention, are scapular problems, shoulder blade problems, and nerve problems. A lot of people do have some shoulder blade pain or shoulder blades that don't really move symmetrically. They're a little wonky when they move their arm up. And that's usually because it's secondary shoulder pain. Because if you think about it, your mind is telling you want to move your arm all the way over your head. But if you have a shoulder problem and it's stiff, you may use more of your shoulder blade to push your arm up to that top shelf. And your shoulder blade has 17 muscles attached to it. And so this shoulder blade has 17 small, tiny muscles that isn't used to do that kind of heavy lifting. And so a lot of times they get out of whack, and they need to be kind of realigned with physical therapy and retrained. The other thing, sometimes there is a primary nerve or muscle problem that is affecting the scapula. And those are things we'll work up with EMGs with a good history. And so that's something that we always try to think about. And the nerve problems are another thing that's not common, but it can cause some shoulder pain. There's some nerves that go around, the scapula right here. There's a big group of nerves called the brachial plexus that go down the arm right here. Those are all things that can potentially cause some shoulder pain as well. So that's a really, really brief overview of shoulder pain. I do hope you guys out there have had some sort of insight on how I like to think about it and approach shoulder pain. And I hope how you kind of try and think about it too. And then one thing I do want to take away for everyone out there is that treatment is very individualized. I've always taught the right surgery done at the right time for the right indication produces the best outcome. And if you do a surgery perfectly and it's not on the right time for that person, it might not be the best thing for you.